monovision is a very good topic to talk about. And then I started thinking, you know something, this is probably the perfect time not to speak about monovision, but rather to speak about blended vision, okay? So words matter. Words are very important, especially at this time when people are so nervous. And monovision, I have it, but it has a negative connotation in the mind of a patient. It sounds like one eye is doing one thing and one eye is doing another thing. And it often makes people think they only need to have the one eye treated. So a much better term is blended vision. It's a lot more positive. It sounds like things are working together, which they are. And then also there's no suggestion of only one eye being necessary. Obviously, often you're going to only have to do one eye, but that's a nice surprise for the patient. When you speak about monovision, people are sometimes surprised they need the second eye done. So I think words matter and blended vision is a better term. So there are quite a few things to consider. One is, which is the right eye for the right task? So most people speak about motor dominance. I've been doing monovision for the last 22 years routinely. So I've done something like 8,000 or 9,000 monovision cases or blended vision cases. And I find people do a lot better with sensory dominance and putting distance vision on their sensory eye. Something that can help you an awful lot too is a phoropter or a loose lens test. And a contact lens trial is also very valuable. Now in the COVID era, we're not doing many contact lens trials at all. So then really the phoropter test is very valuable. You simply show the patient right eye dominant, right eye for distance, left eye for near, swap that around and see which one they prefer. So another question that gets asked is how much should the reading eye be undercorrected? So what we typically do there, I'm going to give you on the next slide, I'm going to invite you to photograph the screen. There's a YouTube link and you can have a look at this on, I've got a 10-minute video on YouTube that shows you exactly how to do this. So the first thing you do is you correct the patient both eyes fully. They look at the Shannon chart and you ask them to rate it when you show them monovision. And anytime they rate it more than 80, you know there's a really good chance it's going to work. If they rate it under 80, then maybe blended vision is not the way to go. But 85% of people rate it above 80. And then you show them a stereo target and you defocus the reading eye until they lose stereo. And then you come back again. So I never do blended vision if it's going to take away the person's distance stereo. They're not going to appreciate that. And then also it's important, obviously, to figure out what your patient's work requirements are. So I'll just leave this here for a second. You can just photograph that if you're interested. And it's a video that shows you how in your rooms, using the phoropter, to do a test that shows you exactly which eye to choose and how to decide how far you can undercorrect the reading eye. This is just another example of a patient who's due for surgery. So this was a patient who we're planning treatment. Cornea looks fine. It's a little bit on the thin side. So we sort of have this unspoken rule that if you are under 500, we tend to go surface ablation. In this case, the BAD was fine, suggesting you could probably do LASIK, but we decided to do surface. And this is the topography again, showing that things look pretty okay. What I want to share with you is the BAD. So in the previous slide, you saw the BAD was 0.83. Now a BAD of 0.83 is 0.83 if the patient is 30 years old. But for every year under 30, you can add 0.05. So if this patient was 28, instead of being 0.83, the BAD is actually 0.93. So you'll see as you go younger, the BAD is becoming higher, making you think more about LASIK, or rather thinking more about PRK than LASIK. And then the same thing for every year over 30, you can subtract 0.05. So if this patient was 6 years older, was 36, the BAD is actually 0.53. And this is from Michael Beelan. Michael Beelan told me this personally. That's how he uses the BAD. And then I went ahead, did a PRK, who of course we use a nomogram. You need to follow your results yourself so that you know what nomogram to use, and also that you know with your technique, in your climate, and with your laser, does mitomycin impact your nomogram? And we normally use 0.02 mitomycin for 20 to 30 seconds, irrespective of the amount of treatment we did. And then this patient got a very nice outcome, but I got a very interesting surprise. And this patient presented with shingles about 10 days later. And this was one of those times, we're normally very good about this, but this was one of those times we didn't specifically ask about a history of herpes simplex and zoster, and we should have picked it up with this patient. So if we do have patients who are having surface treatments especially, and they have a history, we would normally put them on isiclavir 200 milligrams 4 times a day for a prophylactic dose, all the way through the healing period while they're on the steroids.